Back on? Yeah. So welcome back, everybody. We are just about to introduce our next speakers who are joining us virtually today. So welcoming Lorna Nicoll and Jenny Foster. Lorna is the operational lead at Children's North East Charity in poverty proofing, and Jenny Foster is the North East and North Cumbria Children and Young People's Diabetes Network manager. Both have been totally and tirelessly committed to addressing inequalities in the context of the care of diabetes. So welcome, both of you.
Hi. Thanks, Dee. Hi, everybody. I'm so sorry we couldn't be with you in person today.
Just one second, we're sorting out your... we can't hear you yet.
Okay.
Try again. Could you try and speak?
Can you hear me now?
Yeah, we can hear you.
Oh, I can hear me too. That's weird. Okay. Hi, everybody. I'm so sorry we couldn't be with you in person today. We've battened down the hatches and we're really hoping we don't lose power while we're presenting to you today. It's pretty wild out there. So we were invited today to present because poverty proofing in diabetes work is really a direct result of the inequalities data we've consistently seen in the NPDA. So Dee's just introduced myself. For those that don't know me, I'm Jenny Foster, one of the network managers, and I'm going to talk about the history of poverty proofing in diabetes services. But first of all, I'd like to hand over to Lorna. She's from Children North East. She'll introduce herself and explain a little bit about what poverty proofing actually is. Over to you, Lorna.
Said, I'm the operational lead for poverty proofing at Children North East. We're the longest running regional charity in the North East, founded in 1891. But in 2011, just to give you the background of poverty proofing, in 2011 we got some money to do a consultation across the Northeast region. There's 12 local authorities from the Tees right up to the Tweed, to understand the lived experience of children and young people who are experiencing financial difficulty. We distributed hundreds of cameras across the region and we got thousands of photos back. These are just a couple here. And talking to children and young people about the hopes, the dreams, the challenges that they had in 2011, overwhelmingly, they said that one of the worst places to be poor was school. This surprised the team, and it had to be looked into because school is meant to be one of the levers for social mobility. And we worked to create a model for schools to really understand the experience of what school is like. We spent a couple of years making up, interrogating this question, children saying, yeah, well, we can tell who's poor at school, who's experiencing poverty, or we've got a very, very different experience of school because we've got less money than other people, and it affects what we can participate in, and it can also affect how much we can go to school. And from that, we worked with Newcastle University and the North East Child Poverty Commission, and we created poverty proofing, a set of methodologies to understand the lived experience and take that voice to those senior decision makers. And at the heart is our ethos that no activity or planned activity should identify, exclude, treat differently, or make assumptions about those babies, children, young people and families whose household income or resources are lower than others. Child poverty is, there are relative measures for poverty used by the government, but actually what we're doing is we're looking at what is the access. This is really about inclusion, and we've got these three principles at play, at work when we are working with organisations, services or settings. So we recognise that to see real social change, it's really imperative that the voice of those affected by poverty are central in understanding and overcoming the barriers that they place. So it's really gathering that voice, and alongside the hearing, because once you listen, then we also need to understand the context of community in place that we wish to poverty proof. We recognise that poverty impacts places as well as people differently, and so understanding place is vital in our response to that. Organisationally as well, when we're working with organisations and settings, we need to be clear about why and how decisions are made. And so understanding of context is essential to this. And the third principle is that of structural inequalities. While tackling poverty can feel like an impossible, an unachievable goal at times, the knowledge that the root causes of poverty are structural gives us reason for hope, because if poverty can be addressed or at least alleviated by making structural changes within society, what structural changes can we make at an organizational level to eliminate the barriers that those in poverty may face? So what does this actually mean in practice? When we work with schools, when we work with health settings, when we're working with networks, it's different. But just to give you an overview of how we work when we're kind of doing what we call gold standard poverty proofing, so a full poverty proofing audit. And to be honest, we don't really like the word audit, but it's the best word that we've got for it, because it's certainly something that we do alongside services. We don't do it to them, but we have this 6-phased methodology that it starts off with staff training and staff consultation, and moves on into a scoping phase of our members of staff understanding how a service is working in order to prepare the way for consults. In terms of paediatric diabetes, when we've been working with services, that has been reaching out to people within the services who are using it and trying to reach those who haven't been able to access services as well. We gather the information from consults, analyze this, and give it back, feedback to services, and they also get a detailed report, a thorough report outlining what's working well within a service in terms of poverty proofing, in terms of access and engagement based on background, financial background, but also some of the barriers that have come up during those consults for those people, and we go through and we talk through considerations that can be made, and then usually 6 to 12 months, depending on the type of services setting, we'll come back for a review. There's a phase 5 in there that we've not got a box in there, because that's what the services do in the meantime, before we come back for a review. I think it's really important to highlight, when we're poverty proofing, it's not a checklist. It's not something where you can go and say, right, we need to do this, this, and this, because what we're doing at the heart of this in a full poverty proofing intervention is we're gathering that voice, we're listening to it, and we're taking that voice to senior leaders and other decision makers to make a change. Just in terms of how we work as well, we offer standalone training, webinars, lunch and learns, and so on. We deliver events and conferences and input to communities of practice. We have a delivery partner model where we haven't been doing this within paediatric diabetes, but we're, for example, working with RDASH, Rotherham, Doncaster and South Humber Trust, and we're also working more locally with the Northumbria Healthcare Trust as a part of a big piece of work that we've got with our local ICB. We also produce materials, toolkits and resources, which we've done in collaboration with the network, and we also offer bespoke half-day workshops, which we're hoping to tempt you to come along with, because we have got a whole range of those that it is available for the networks to join up to. So we'll talk about a little bit more about that a bit later on, but just the range of our work covers this and more, and this is just within health, and we're also starting to work cross-sector to look at, right, how can we start joining up the dots with schools, with the culture sector, you know, with family hubs and so on and so forth. But paediatric diabetes has been a really important part of our journey, and we've got a fantastic collaboration, and you're like the heart of our work that we do. So I'm just going to hand over to Jenny now, who's going to talk a little bit more about that.
So we thought it would be a good idea to just spend a few minutes describing the kind of ripple effect that poverty proofing has had across paediatric diabetes. I apologise for this busy slide, but my colleagues will tell you I really love a timeline. As you can see, the history of poverty proofing in paediatric diabetes goes way back to 2021, when Dr. Reid from Gateshead saw an opportunity to put a funding bid into our Child Health and Wellbeing Network to be the first ever health setting to participate in a full poverty proofing programme. The bid was successful and it ran out through 21 and 22. And as with everything in paediatric diabetes, news travelled fast. On hearing of the work in Gateshead, 2 teams from our neighbouring network, Yorkshire and Humber, saw another opportunity to secure funding to deliver the programme within their teams. And if you were here last year at the NPDA conference, you'll remember Dr. Gupta from Hull presenting the success of the project in his team. So while the programmes were running out in Hull and Grimsby, the NHS England Inequalities funding was launched out to regions in October 2022. The North East Yorkshire regional lead and today's lovely stand-in chair, Dr. Aswani, spotted another opportunity to roll out a condensed version of the training across the North Eastern Yorkshire region using some of the NHS England Inequalities funding money. So my colleague Emma Savage and I then worked with Children North East, all of Lorna's team, to deliver 7 training events in early 2023, which I really can't believe was already 2 years ago. But across the 7 events, 210 healthcare professionals attended the training from children, young people's MDTs and Q teams from across North East and Yorkshire. The training received overwhelmingly positive feedback, with 99% of participants recommending the training to their colleagues. Diabetes UK went on to feature the poverty proofing work in their Tackling Inequalities Commissioning report later in 23, and the RCPCH agreed to include generic poverty proofing training to their HCP online curriculum, with the first course taking place last summer. So that brings us to what's happening now. At this very conference last year, in fact, in that very room you were all sat in, conversations began between Fiona Campbell, Fulya, Dee, Emma and myself about opportunities to develop a national rollout of poverty proofing training. I think you're all getting the picture here that when we see an opportunity, we grab it. So in response to the consistent inequalities seen in the NPDA data, and with the evidence of tangible projects making a difference across the country, Fiona was able to secure funding from the RCPCH to roll out the training across the country. So these are the 2 reports that were written in 2023 after the North East Yorkshire training rollout. They can be found by scanning these QR codes, and I think the slides will be shared afterwards, so you can pick up the QR codes then. And finally, I just thought I'd quickly highlight some of the quotes from the evaluation so you can see what your colleagues who have already attended some poverty proofing training got out of it. So some were to say that the session had made them look much more closely at their caseload and with a different view. It gave them a greater understanding of the subtleties of poverty affecting access and the impact on health. It made them more aware that poverty is not necessarily visible, and it normalised conversations around finance. The sessions completely reframed their understanding of what poverty truly looks like and gave them a better appreciation that poverty does exist in their cohort. I'll pass back to Lorna now to share some of the barriers to accessing diabetes services that were found during the training and what the next steps are.
Thanks, Jenny. Yes, and thanks to that early work that you know, within Gateshead and beyond, down in Yorkshire, in Hull, etc., we've been able to gather some common themes that are really great starting points just to start thinking about and discussing within teams. And these are barriers that we're going to go into more detail within those one-day workshops. So I just wanted to give you an overview of the kinds of things that you'll be discussing. If, you know, we hopefully everybody will be able to come along, and your colleagues will as well. So, you know, things coming out, barriers related to travel in terms of affordability, where the setting location is that the patients need to go to, the transport poverty that the patients and staff often have. You know, even staff telling us, if I've got to get in on a Sunday, it's impossible because the bus services are different. Just to really understand that. And, you know, whilst things like transport and travel are a really obvious one, but actually, do we know that people are being reimbursed? Do we know how easy the reimbursement scheme is within our patch? Really understanding that journey within itself is really important. Navigating and negotiating appointments. You know, there's hidden costs that we may not see and we may not appreciate. You know, if I'm on a 0-hour contract and I've got to take my child for an appointment and I don't get paid during that appointment, and then it gets, you know, I'm delayed by it, that has serious consequences to my household finances, my budget. Also, if I've, you know, how many buses does it take to get to that setting? Or even things like, you know, taking my child out of school to that, if they're eligible for free school meals and they're going to miss that free school meal, have we even thought about, you know, have we've got some joined up thinking across the sector, or just, you know, fruit or crackers available within appointment rooms? And also the, you know, flexibility, accommodation, and the system and the process for navigating appointments, for setting them up. If, you know, you don't have data, if you don't have a phone, things like patient empowerment is really, many people have told us that, you know, they don't feel that they've got a voice, or that if they try to use it, it's not necessarily heard, and that perception of the system, because quite often, whether we're a school, whether we're an NHS organisation, you know, we're seen as the system. And what is my relationship with the system? What are my perceptions of it? But particularly at the moment, with just how divided, and this is Lorna Nicoll speaking, not Children North East, but with how divided the you know, the globe feels, and what feels like a really diminishing middle class, the division between the haves and the have-nots are huge. And so this is really important, and that kind of staff awareness and guidance around this, the way that we guide as well, the knowledge and awareness of signposting, of the partnerships, and that kind of joined up working, signposting and referrals, and what does that feel like for the person or the people being referred and their families, and just all of the communication that's, you know, related to digital, health literacy, how accessible is it? What are people's preferences? Are we reaching them? Is there language and cultural support that's required? And just all those health related costs, including technology, prescriptions, specialist equipment, and food and health related activities that we know are required for those who have diabetes. So what we plan to do within our workshops is to have explore this in further details using those two tools that the reports that Jenny sent the QR code for, but to really start unpicking and understanding, first of all, what is poverty? What is it like to live in poverty? Some of us may know, some of us might have experienced it as children, some of us may have experienced it as adults, or maybe experiencing financial instability currently, but to really take it on a journey, because actually with our work, and we've really learned this with our collaboration with paediatric diabetes, is that it is a journey. And we hope that it's like almost like unpeeling an onion. There's always another layer. And what we're hoping to do is leave everybody with poverty proofing glasses to think, right, I've got to look through what's in front of me through a number of lenses, but one of them we're saying needs to be from the perspective of poverty and those who are people who are struggling the most within society. So we really encourage you to sign up for these half-day workshops. You're a great network to work with. It's fantastic, the amount of energy and the amount of oil that you must have greased this network with, and that is extra time and energy and motivation, and people like Jenny, Dee and Judith have really been great champions, as are their RCPCH and everybody else who's been involved. So please do book via your network leads. And I think I'll just pop it onto the last slide, and just, I suppose, open up for questions. It's really frustrating not to be there, but do contact myself or Jenny if you've got any further questions. Jenny, I don't know if you want to say anything else.
Got some good sign up already to the workshops, but really want to make sure that these amazing messages are spread across the whole country. So contact your network manager, and they'll make sure that you're aware of where and when the workshops are happening in your area.
Thing I'd say is please sign up as whole teams. You have much more power if you invite your managers and you go as teams to share ideas, because many things that you can put into place are not going to cost, but are also not going to be that effective if you're just a lone voice. Are there any questions for Jenny or Lorna? No questions? I don't know, Sanjay, if you'd like to. Yeah, Justin.
Just a comment about, you'll be aware of the first year of care patient reported experience measure that we published from the RCPCH, which has also churned out a whole load of sort of inequalities that parents face when they have a child diagnosed with diabetes, with, I can't remember the figures exactly, but I think it's around 30% who either have to give up their job or reduce their hours of work. And there's a huge bit around sleep deprivation in the first year following a diagnosis.
Could you pass that to Sanjay?
Thank you very much. And I'm just talking from Hull team side. So I think the two interventions following the poverty proofing intervention, which have worked really well. One was about adding a question relating to finances in the well-being questionnaire, which we check annually. Because previously team was very skeptic, if we add and if they're saying, yes, we are struggling with finances, what can we do? But following that, we have identified various venues where we can signpost them to. And the second one was like, getting our business manager on board and getting free food vouchers for children who are waiting around lunchtime. So initially we started giving it to asking the parents, would you need it? And nobody volunteered. And now we are just giving it universally to all the children who are waiting between 11 to 12:30. And the uptake has been very good. So, and I think having undergone this training, I think the team ethos has totally changed. I think it's no longer the same, because at every stage we are thinking, are we excluding particular children and young people because of their deprivation? So no, it's been very useful. Thank you.
Thanks, Sanjay. Is that one more question at the back? Or no, one more.
Hi, thank you for that, and it's really nice to hear that presentation. So passionate about what you're doing. It's really good to see. I just think that slide that you had near the top about equalities, equities and justice is one of the most important slides, and one that's really worth emphasising, because I don't think people really understand the difference between equality and equity, and I think that just is something that I think is worth that staff awareness, that training to understand that yes, we offer these appointments to everyone and that's equal, but actually not everyone is able to do that. Yeah, that slide, I just think it's really worth emphasising. So thank you.
Yeah,
Thank you.
Yeah, equality, you give everyone the same. Equity, you give everybody what they think they need to be able to get it. Justice, you just take away the barriers completely. Like Sanjay just said, just give everybody a voucher and then everybody can access it. If you can, we know this isn't always, universalism isn't always possible, but there are other ways of doing it. Yeah, thank you.
Can I just mention as well, Dee, on the back of obviously the poverty proofing training, most of you will probably know that in the North East we've run a programme of being able to refurbish NHS mobile phones to give to families. And what Lorna's just said there about justice and taking away the barriers completely, and echoing what Sanjay said, we offer this to everybody. So this is a universal offer. And actually what ends up happening is the people that really need it are the ones that end up accessing it. Because if it's just offered to those people who we judge need it, quite often they'll be embarrassed or shy or not want to talk about it, or not want to take what they're perceiving as charity. But if they just think it's a universal offer, they are more likely to accept it. And we found that absolutely is the case with our mobile phone project. So I think it was really key to put that slide back up, actually.
Thank you, both of you. Could you put up the slide where you've got the training dates, and could everybody just take a picture of those training dates before we move on?
Can I just mention as well,
as soon as possible.
There's a date missing, I think. The 5th of March, there's some training in the Southwest. So there's another training date in there. It may have been arranged since the slide was drawn up, but yeah, if you're in any doubt, speak to your network manager. And can I just do a big shout out to the network managers for supporting the rollout of this. They're already very, very busy people, but have really helped to put this together, this programme together with Children North East. So thanks to all my colleagues.
Thank you very much, both of you. Round of applause, please. So next I'd like to introduce our fabulous National Clinical Lead, Dr Fulya Mehta, also a consultant paediatrician at Alder Hey, and Fulya is going to talk to us about the national strategy for reducing health inequalities for children and young adults living with diabetes.
And thank you very much for the invitation to talk today. Let me just double check I know what I'm doing.
Sorry, what's that?
Oh, I've gone too far. Okay. So as Dee said, I'm the National Clinical Lead, but actually now National Speciality Advisor for Children and Young Adults Diabetes in NHS England. Thank you for the challenge of this title of converting strategy into better outcomes for children and young people living with diabetes. It was a good opportunity for me to have a think back to the journey we've taken within NHS England over the last nearly 3 years, of when we first started, thinking we have this problem and we need to do something about it, and what can we do as policy leads to try and narrow that gap and improve outcomes in these groups that we're all so worried about. And I think it's really important to say that the work that I'm presenting today is the work of many, many people. So huge thanks to the NHS England team. But also we work very closely in partnership with the National Children and Young People's Diabetes Network, so with Fiona Campbell and all of our many network managers and clinical leads, with the National Paediatric Diabetes Audit, and of course with huge thanks to all of the units who contribute to actually delivering the care and submitting the data on which so much of this work is based. So as many of you know now, we have a children and young people's diabetes work stream within NHS England, and the real beauty of this work stream is that it brings together the children and young people's work stream at NHS England and the adult diabetes work stream. So that gives us a huge amount of opportunity to influence and develop policy in this area, and to make sure that the really important voices of children and young people and those of us healthcare professionals working in this area, to make sure that our voices are heard and that we can influence policy. As you know, we have 4 key areas of focus, and it's important to note that these areas of focus were very much developed based on what the data was showing us, and the areas that we could very clearly see we needed to start to deliver improvements. And top of the list is addressing diabetes health inequalities in children and young adults living with diabetes. And although that's what I'm focusing the talk on today, actually you'll see through all of the key areas of focus, there is this overarching theme of health inequalities, because there's variation in care and outcomes depending on where you live, and often where you live, there will be an element of influence of socioeconomic factors, and we know we have areas across the country where there's more children, young people who are of different ethnic backgrounds and so on. Transition and young adult care, again, I'm not going to talk about this today, but we know we have much poorer outcomes for this age group. And again, it's an area that we need to focus on in terms of tackling health inequalities. And finally, type 2 diabetes. Again, we know we have health inequalities there. If we compare, for example, care process delivery, that's much lower in young people living with type 2 diabetes. And we know that these young people are more likely to, young people from different ethnic backgrounds have higher rates of type 2 diabetes, and those living in more socioeconomically deprived circumstances have higher rates of type 2 diabetes as well. So again, really important areas for us to focus on with this overarching theme of health inequalities. So I've taken this image from the National Paediatric Diabetes Audit Extended Analysis for the last audit year, because I honestly think that this is one of the most powerful images, one of the most powerful charts that we have within our audit. So with huge thanks to the team for the amazing work that they do with the extended analysis, because without even looking at the numbers, it gives a very, very clear picture of what our outcomes are like based on socioeconomic status of these children and young people that we look after, and based on their ethnic background. And I think we all recognise that there's some intersectionality in these groups, but we can very clearly see that we're getting different outcomes based on children and young people's backgrounds. And I think that, anything that you're doing to, whether it's business cases or anything you're doing locally to try and improve outcomes, I think this is such a powerful image to use. And I think it makes the case for focusing on this area very, very clear. So I'm going to talk through the things that we've done over the last 3 years to try and influence influence policy, develop policy and improve outcomes in this area. And we've got some things that we've done that are sort of overarching pieces of work, and then we've got some more focused projects that we've done, and I'm going to use the last bit of time to focus on the Getting It Right First Time programme. And so very fortuitously, Dee's sat at the front here, so I'm sure that she'll chip in with any useful bits of information that I miss. One of the very first things that we were able to do was to make sure that we had diabetes as one of the key areas within the Core 20+5 framework. And I think that I think this has been so important because, as you'll all recognise, the NHS operating model has really changed over the last few years, and it's changed since I've been in post. And where we previously had the opportunity to do a lot of things at national level, to earmark funding for specific projects, there really has been a huge devolution in terms of where the decisions are made and how the purse strings are held. And it is very much all now ICB-led. So it's really important as a national team, when we're thinking about what we need to do, thinking who do we need to influence and how do we best equip our teams with the tools to be able to influence the decision makers. So I think that this was a really, really good bit of work that we were able to do early on to make sure we had diabetes in the core 20+5, and we focused on the things that we thought would make the biggest difference to influence outcomes. And that was access to treatment technology. Now already it feels a little out of date, I have to be honest, which is testament to how quickly we are moving in the world of type 1 diabetes. So it was access to real-time continuous glucose monitors and insulin pumps. But I think we'd all agree now we're talking about HCL, aren't we? And then secondly, in terms of care processes for children and young people living with type 2 diabetes, which we know is extremely important given the high rates of comorbidities and complications that they experience. And I think what's really helpful is that this is on the agenda of every ICB. So if you are struggling with, maybe workforce or securing funding, this is a really good sort of opener to kind of pin your argument on, to say this is something that the whole country is working on. Another thing that we worked very hard on developing is the Children and Young People's Diabetes Right Care Toolkit. And it's very much, it's basically, I remember when Fiona Campbell and I were first talking about, should we develop a right care toolkit, what would its role be? And I think the way that Fiona described it was, we need a manual, we need a handbook for delivering high quality diabetes services. And we want that for services, but actually it's become increasingly important that we have that for trusts and for ICBs. And actually, as we were writing it, it very much evolved into a toolkit for ICBs. So it's aimed at ICBs, but actually I think it's useful across the board. And again, if you have, managers in your service, if you want to have conversations with finance people in your service or with your ICB, this is a really, really useful tool, and you can dip in and out of it. So there is it's built around the 4 key areas of focus, but there's there are really key pages on tackling health inequalities, and you can dip in and out of it and take the bits from it that you need that will be useful for you. So if you've not looked at it, I would really recommend having a look at the Right Care Toolkit and thinking about how you may be able to use it going forwards. So this is, I just wanted to bring this to everybody's attention. So this is a toolkit developed by a charitable organisation called Diabetes Africa, who we've been working at in thinking about how we tackle the issues that we've seen in terms of the poorer outcomes from children and young people who are black, and the lower rates of them using diabetes treatment technology. And in collaboration with key experts in the area, there's NHS England representation on the writing group as well. They've developed a toolkit called Advancing Equity in Diabetes Treatment Technology. So if you've not seen it, I highly recommend that you have a look at it. It's only a few pages. But I think that probably a couple of take-home messages for me in terms of working with the organisation and going through the toolkit is this issue of, I think we've talked a lot in the past about cultural competence, and a sense that if we can learn about different people's backgrounds and cultures, then we will be able to develop our services that will meet their needs. But there's a section on cultural humility in here, and I think this is a really important concept for us to all understand, which is that actually, even within groups of people who seem the same, there's actually quite a lot of difference. And there is nothing that's more important than spending time to get to know the child, the young person, and the family that are in front of you, and having the opportunity to build relationships and then together work out what's going to be the right thing going forwards. So highly recommend just having a little look at this toolkit and then thinking about things that you may be able to do within your service to, continue the really good work that everybody's doing on improving outcomes. So huge thanks to DigiBeat, as always. Absolutely fantastic resource, which I'm sure you're all using. But again, early on, we were able to commission some additional resources so that the key technology videos are now in the 10 most used languages, and hopefully that will be a really helpful resource for you all. And also just to mention the Type 2 website and resources as well, which I think is a really important additional tool that you can use in your clinics if you're not using them already. So now thinking about some of the more specific work that we were able to do. So we were extremely fortunate to be able to secure some funding specifically to start to work on tackling health inequalities. And I'm sure all of you will have seen the dashboard that we were able to develop within NHS England using National Paediatric Diabetes Audit data, but displaying it in a way that our regional leads, ICB leads, and then also within a unit, we could very clearly look at the gap in terms of access to treatment technology, which I think then enabled us to identify areas where we could see amazing practice. And actually, we've all gotten very used to seeing the gradient in terms of treatment technology usage. But actually, we could see that there were some areas where that was pretty flat, and some services had actually already managed to deal with this issue, and we could see other services where there actually was quite a big gap in terms of access to treatment technology. What that enabled us to do, or I say we, I mean actually I'm a huge credit to our regional leads, ICB leads and network leads as well. What that enabled was conversations to happen, to explore the data in more detail, and then for us to also identify units or areas that could benefit from some targeted funding. So as you're all very aware, we had lots of projects that we were able to fund across the country. We've already heard about the poverty proofing project in the North East that was able to be rolled out across the North East, which has been incredibly helpful and really, really positive feedback. The mobile phones and laptops projects, and then lots of projects across the country that have delivered some amazing outcomes. We've had more than 2,000 technology starts, and 60% of those have been in children and young people that are from the most socioeconomically deprived backgrounds or from different ethnic backgrounds as well. So fantastic work that's been done. But I think it's important to recognise that not only has it made a difference within those units that had the funding, the impact has been far wider than that, because these projects have been presented in so many forums, in network meetings, in meetings like this, and that learning has been shared. And I think the second really powerful thing about these projects has shown that it can be done. So we recognise that there was money invested in a lot of these projects, which has enabled boosting of workforce to, run, let's say, pump start clinics at the weekends or the evenings and so on. But there's also been a huge amount of learning about the importance of culture within teams and how we approach, young people and families in terms of offering the technology and identifying what some of those barriers are to accessing treatment technology and how we can work towards eliminating those barriers going forward. So I think that the benefit has been that we've all been, what the money has enabled is that we've all been able to focus on tackling health inequalities much more, and there's been a huge amount of learning from these projects. So, as we all know, access to hybrid closed-loop technology and the NICE TA has been a game changer for us. I think as paediatric teams, we all knew this was the right thing to do and really wanted to crack on and be able to do it. What the NICE TA and the funding that's gone with it has enabled is that now this can be, and in many areas already is, a universal offer. And I just wanted us to have a bit of a think about that, because I actually think one of the biggest barriers or one of the biggest issues that has caused some of these health inequalities is the fact that diabetes treatment technology has not been a universal offer over many years. And we know that when it's not a universal offer, we always see health inequalities, because there are always some people who are much better able to advocate for themselves and advocate for their children compared to other people. And so inevitably, when it's not a universal offer, as healthcare professionals and as teams and as services, inadvertently we end up putting barriers in place, and then that always leads to health inequalities. So I think it's really important now that we will have this universal offer going forwards, and as teams we need to very much think about it as a universal offer and recognise that this is the treatment of choice for children and young people with type 1 diabetes, and we should be offering it to everybody. And by offer, it was interesting to hear Julian talking the sort of analogy with cancer treatment, and I think that with cancer treatment, we very much say, if your child has cancer, or if you have cancer, there's a sense of what is the best possible treatment that's going to give you the best possible outcomes. And that's what you get offered. And very few people say, no, I don't want that best possible treatment. When it comes to diabetes treatment technology, I think, and totally understandably, and we've all been there and done it, including myself, it's been, well, there are options. There are options in how you manage your diabetes. You may want a pump, you may want continuous glucose monitoring, what's going to be right for you. And of course, it still does have to be like that. But I think we need to reframe how we're having the conversations to say, this is the best treatment we have to offer for you, for your child, and let's work with you to get you on the best possible treatment. Now, of course, don't get me wrong, I'm not saying that it will be for everybody, but it's about framing the conversation in that way, I think, going forwards. And I know that many of us are doing that now. Okay, so I just wanted to take a moment to reflect on how amazingly we are doing in the paediatric world. So this is the obviously the dashboard, which you've seen a few times now, and I must say huge thank you to all the teams that are submitting data, and huge thank you to the NPDA team for making this dashboard happen, because I know that this was a massive ask. And recognising the fact that it's not validated data, I think that we can all see that this massive increase in children and young people using hybrid closed-loop technology is really something to be celebrated. And I have the date in my diary for the dashboard refresh, because I'm very excited to see what the latest quarter is going to show. But I think that this is an amazing achievement, and I actually think we're going to get to very high levels very quickly, probably much higher than I had predicted, I've got to be honest. So huge thanks to everybody for all of their hard work. We do still have some health inequalities, and I think that's understandable when we're rolling out newer treatment technology, but we're all very mindful of this and working on it, so I'm confident that we are going to slowly close this gap over the next, well, I say slowly, I think we'll close the gap relatively quickly with all of the work that we're doing. Okay, so I've just got 3 slides on type 2 diabetes. So as we all know, we've seen this really rapid rise in the number of children and young people living with type 2 diabetes that we are looking after in our paediatric clinics. So about 10 years ago, we were around the 300 mark, and now we're up to 1,245 children and young people living with type 2 diabetes within our paediatric services. And our early conversations and work on this very much identified the fact that as paediatric teams, we really lacked confidence and felt that we didn't have the skills to look after these children and young people as well as we should. So our strategy has very much been focusing on upskilling and supporting healthcare professionals. So I don't have a slide on it, but I must say a massive thank you to the network and to the Type 2 Diabetes Working Group for the absolutely amazing training days that they've put on that have been hugely well attended. I can see Heather in the audience there, and I think, and they've been extremely well received, which tells me that we're on the right track in terms of focusing on healthcare professional education and support. Just a plug for the e-learning for health modules. Bit of a labour of love, would you say, Dee, developing these modules, but there's, again, loads of information there. And there's 6 modules, and you can very much dip in and out of the sections that are most relevant for you, but I'd highly recommend taking a look at the modules and recommending them to your teams as well. And then again, just as an example of the value of having the national programme where we're working with the adult diabetes team, and we've got the children and young adults diabetes team, is the T2 Day programme, which has enabled us to focus on type 2 diabetes that's early onset. So we know, and we very much know through the GIRF reviews as well, that many young people, and this is thinking up to the age of 25, are actually cared for in primary care. And we know that type 2 diabetes in primary care, it's treated the same. So whether you're 20 or you're 70, it's treated exactly the same. But we all know that when you're younger and diagnosed with type 2 diabetes, it is a much, much, much more aggressive condition. And you need significantly more input and support to manage that condition well. So the T2 Day programme and funding has enabled us to put that spotlight within ICBs on early onset type 2 diabetes. So children and young people should be in specialist services, and part of the programme is around case finding and identifying those young people and referring them into specialist services, so paediatric services for those who are under 18, but also really importantly for those under 25, which is, my remit, is making sure that we're sure we've got the diagnosis right, because that's often a key issue, and then thinking about the additional wraparound care that those young people need. For example, ensuring that we've, optimised treatment, there's preconception advice and care, and so on. And any other support that they may need, including referral into specialist services if that's needed. So moving on to another one of our key areas of focus, which is tackling variation in care and outcomes in children and young people's diabetes, and thinking about our GIRF programme. These are graphs taken from our Right Care Toolkit, but again, it's National Paediatric Diabetes Audit data. When we look at outcomes and care across ICBs, we can see that there is a huge amount of variation. So you can see that our median HbA1c varies from 56 millimoles to 64 millimoles across systems, and if we're thinking about individual paediatric diabetes units, ranging from 53 all the way up to 70. And in terms of care, all 6 healthcare checks for type 1 diabetes, the variation between systems is from 33% up to 84%. And much of this variation is unwarranted. So, Justin showed the slide of when we look at mean HbA1c and, accounting for those variables. So we have the adjusted mean HbA1c. And that's really helpful for us as units. I've definitely used the mean adjusted HbA1c to reassure myself that as a unit we're doing a pretty good job. I work in an area where there's a huge number of our children and young people live in relatively socioeconomically deprived circumstances, so it always makes me feel slightly better when our adjusted HbA1c jumps up a bit compared to our actual mean HbA1c. So it's helpful for us as units to look at that. But actually, the flip side of that, and to me the more important side of it is, it's not okay for children and young people who are living in more socioeconomically deprived circumstances to have higher HbA1cs compared to those who don't. So I think it's really important that we recognise this variation and recognise that some services, some ICBs, some teams need additional resource to be able to look after these children and young people, because what we want is for everybody's outcomes to improve, and it shouldn't matter where you live, you know, where you're from, what your circumstances are. And so that's where our Getting It Right First Time programme comes in. So, you know, I was really, really delighted that we were able to push and push and push, and eventually we were able to secure a programme to enable us to review all of our systems. There was a little bit of, you know, I think right at the beginning trying to decide, should we review all the units, do something closer to peer review, or should we review systems? And I think we landed on the right decision, which was to review systems, particularly given the fact that it's systems, it's ICSs, ICBs who are making the decisions around commissioning and funding for all of our diabetes services. So it very much now feels like that was the right decision. And we were able to do that through Getting It Right First Time. So the GIRFT approach, which is a mechanism for identifying and understanding and addressing variation. And we very much feel that it's a key mechanism for us in terms of delivering the strategy of tackling variation in outcomes. Many of you will have already had your reviews. I think, are we halfway through, did you say, Dee? So, as many of you know, but just for those of you who have yet to have your reviews, the way that the model works is it's very much based in the data. So we gather a broad range of data. The vast majority of it is NPDA, but we also use data from other sources as well to give us a picture of what's happening within an ICB, including the individual units within that ICB. And then we have a huge amount of clinical engagement. So Dee does an incredible job of having pre-meets with systems and units to be able to get under the skin of what the issues may be. And then we have our GIRFT meeting where we go through the data pack in detail and we talk about what's going on and try and understand what's happening with that variation, and then pull together what the key themes are so that we can decide what the key recommendations need to be, which then all comes together in a report that gets sent to the ICS and to all those involved pretty speedily, I would say. But we've probably had a bit of a blip over Christmas, but you actually do get your report very quickly to enable ICBs to put action plans in place. As part of the whole programme, we will be pulling together a national report, just started working on the national report, and then there's opportunities for further work from there, such as best practice guidance, and we're very much starting to think about what the next steps are for the GIRFT programme as well, and what's going to be most helpful for teams and systems in terms of how we can support as a GIRFT programme. So just to say, this is a really nice slide that Lucy from our NHS England team has prepared, but I think the key message around this is that the actual GIRFT review is a very small part of the whole process. And I think what we've already identified and what we really wanted was that even before you get your review, we recognise that there is a huge amount of work, even to the point of identifying who the right people are. And it very much has brought everybody together across the whole system who is involved in children and young adults diabetes care. So people within the ICB, commissioners, all the way through to key people within the trust, to diabetes services, young adult services, and it's very much brought everybody together to start to have those conversations, look at the data. And I think it has been very eye-opening for many systems, I would say. And then, of course, you have your review, which hopefully is very helpful, and you have your report with recommendations, and then there's a huge amount of work that follows from that in terms of implementing those recommendations. And again, So many people are involved in this across the board, from our regional leads, our ICB leads, the Children and Young People's Diabetes Network, and all of the teams who are involved as well, of course. And I'm just finishing with some slides. So this is my own, so it's the units aren't identified, but this is my own system. And it's just giving you an idea of the sort of data that we're able to produce. So if you've already had your review, you'll be familiar with these charts, but it's a big system. But if you think about it, this is one system which theoretically is commissioned by the same people in the same way, and yet look at that variation in HbA1c. And Dee does an amazing job of getting under the skin of that data and understanding what the issues are. And it's a mix. It's a mix of things around, often workforce is a huge challenge. There's issues around commissioning of services, best practice tariff and transparency around funding. There's been issues around access to treatment technology in some systems where some areas have had relatively free access and others haven't. So we really start unpick those, well, do our best to unpick those issues and try and come up with helpful recommendations for teams and ICBs. And again, this is care process completion. So again, you can see a huge amount of variation there. But the other really positive thing is we get some amazing sort of case studies of really, really good practice. So things around retinopathy screening, healthcare checks. We've seen some fantastic areas of good practice, which we're able to share within the ICB, but of course we can also pull them together for the national report, and then thinking about what we can do to support improvements nationally as well. And then again, so we use the sort of the dashboard as the framework for some of the charts that we use as part of the GIRFT reviews. But this is pump use, again, it's the same system, pump use by deprivation. So we can see that the darker blue is in those children and young people living in the least deprived circumstances, and then the lighter blue is those children and young people living in much more socioeconomically deprived circumstances. And we can see that in some areas there is a gradient there, but in other units, actually it's pretty flat. So I think it's really helpful to see that it can be done, and there's a lot of learning that we can take from this. And I think one of the massive success stories is continuous glucose monitoring, where we've pretty much had universal access for a little while now. And what we can see is where we have universal access, and I think the ethos now for all of us as healthcare professionals is very much everybody should be on a sensor, and we do it from diagnosis. We don't really say, would you like a sensor or not? We kind of go, everybody should be on a sensor. It's just the right thing to do. And what we see is we have really high rates of children and young people being on sensors, and then not only that, we don't see health inequalities anymore. So I think this is a really key message, and I think this is the sort of this is what we will be applying to hybrid closed loop therapy going forwards as well. And I know some people may say to me, oh, but there are other things to consider with hybrid closed loop therapy, and of course there are, and I'm not suggesting that it's quite the same as giving everybody a sensor, but I do think that we need to approach it in a similar way, in that it should be for everybody, but there'd have to be very, very good reasons why we wouldn't be using it, and that's the way that we should be approaching it now. And again, this is just looking at the dashboard. I won't dwell on this because we've probably had quite a few pictures of the dashboard now. There is one thing I just wanted to comment in relation to the dashboard, which is absolutely amazing and incredibly useful in terms of converting strategy to better outcomes. This real-time, as close to real-time data as we can get, is an absolute game changer. So when I am arguing the case for things, the fact that I now have this data makes a massive difference, because when I first started and I was having to use data that was from the national report that was, a year, 18 months old, the pushback I always got was, yes, but what is it like now? And similarly with the GIRFT reviews, if we were using data that was a year, 18 months old, we would have units or systems saying to us, yes, but we know it's much better now, so actually that's not a problem. But if you can't prove it, or if you don't have the data to back up what you're saying, then how do we know? So this data is actually incredibly important for us, and I can't thank all the units enough for submitting, because I know it's painful. I know it's a painful process for all of us. But a couple of things for the dashboard, and Amani and I have spoken about this. I think one of the really important things for us going forward is the ethnicity, is the white, non-white, which, you know, I know we're working on changing that so that certainly for nationally and regionally and possibly ICB level, we can break that down. I don't know whether we can do ICB level, Amani. We'll look into it, but we can break that down into the different ethnic categories, because I think the one thing that we would all agree on is that's incredibly important for us, and this categorising as white and non-white is not what we need to do. We need to understand the data to a deeper level so that we can really focus our efforts where we need to focus it. So I'm sure that's going to be something that we'll have. So I know it's on the work list, and I know you're doing a million things, but that I think that's going to be something that's going to be really important for us going forwards. Okay, so thank you very much.
Thank you very much, Fulya. We are a little bit over time, but we've got a whole hour for lunch, so we can have 2 questions and then the rest in over lunch. Julian?
I'm going to say something slightly contentious here, but let's see how we get on. Type 2 diabetes shouldn't be looked after in type 1 diabetes clinics. They should be separated. We've done that in Bristol. We've moved them all into complications of excess weight clinics. We've seen significant number of remissions. I can't tell you the exact percentage. However, everybody is working towards different goals. Weight loss, which is important. And if you lose 10% of weight loss in a Q clinic, everyone claps. If you lose 10% of weight in a type 1 diabetes clinic, everyone's jumping up and down, saying how they got an eating disorder. They're very different conditions. And my suggestion is that actually we're probably looking after them in the wrong clinic. They should be allied to the diabetes clinic, because we've just got 2 consultants. We've got one PDSN who does all the type 2 diabetes patients. We've got a different dietitian, different psychologists. We've got social workers in that thing as well. Some of the things that people with type 2 diabetes need even more. So I'm not trying to be contentious, but what do you think of that argument?
I don't think it's contentious, so I completely agree with you in that we need people who absolutely know what they're doing with type 2 diabetes, and it is very different. And we have a very similar setup in Liverpool as well, which is we have a separate type 2 clinic, and it's one of our diabetes clinicians, it's one of our Q clinicians, and they work together and look after these children and young people, and it works really well. But we look after more than 500 children and young people, and we actually don't have, we're maybe sort of 12, 13, 14 children and young people living with type 2 diabetes, just because of where our service is based. But we can do that. You can't do that everywhere. So there are many services that might have 100, 150 children and young people living with diabetes, of whom, 1, 2 have type 2 diabetes. So then you come into the argument of should they be in a specialist centre? But we also know that actually asking these families to travel or for their care to not be local is an issue. And so I think that's where the MDT approach that the network the healthcare professional MDT approach that the network have developed is really key, because it's about building expertise in not all clinicians, but in clinicians who are delivering type 2 care, and then to work as a network to think about those cases, review those cases, and to get input from people with expertise with those patients. So I think in an ideal world, absolutely, but it is just thinking about what would that model look like across all centres, and I don't think it would be feasible in all centres. So it's thinking what can we do to try and give the best possible care for those children and young people.
I can see all your arguments. One thing I'd say is now 43 Q clinics clinics in the country. 1,000 people divided by 43 gives you a degree of experience of about 20 patients per centre, and they do run hubs, and I think it's just something we should think about now.
Yeah, I think it's a very good point, and as the key clinics are expanding, we can start to think about what that should look like.
Thank you. One more question for anyone? Martha?
So much, Fulya. It's very good. One thing I think we all really need to do is we can't analyse ethnicity unless we have the data.
Yeah.
So we made a real big thing in our clinic of, asking everyone at diagnosis. But people sort of, they're just, the amount of people that's just like not disclosed or not this and not that. And I think we have to. I mean, you can do deprivation because the deprivation data is given to you. I'm sure an awful lot of patients don't even know they're living in 3, 4, 1, 2, whatever. So we have to ask the questions, and we've still got a big chunk in the audit of, well, we've got these very odd categories of mixed and other. Like, what is in there? So I think, we need to think about that, and we need to really drive through in the fact that, people will give you their ethnicity, but we need to ask them in the right way.
I think you're absolutely right, and then record it, and that's one of the things that Dee always picks up on in the GIRF reviews, as if actually there's a high proportion where it's not stated. That's almost a red flag to say, okay, this is an issue, and that's something that needs to be looked at.
Thank you. Thank you very much, Fulya. We will close for lunch now, and if you could come back, please, at about 5 to 2.